Hi. So Dr. Basina is here from Stanford. We're super excited. She is an awesome endocrinologist. And yeah, I'm just super psyched. F diabetes. And yeah, thank you so much for coming.
Thank you. Good morning, and I hope you're all having fun. Can you hear me well? Okay, great. I guess I'll stand here because I'll have to change the slides. Oops. I don't think I can move it. I'm afraid to touch anything. All right. So I guess the topic for the day or for the morning is the cystic fibrosis-related diabetes, its diagnosis, significance, and also what are the treatments. So what is the epidemiology of CFRD? So it is most common complication of cystic fibrosis. 2% of all the patients would be develop diabetes as in their childhood, and 20% in adolescent, and 40 to 50% of the adults. So average age of onset is about 19 to 20 to 21 years. So what are the risk factors for developing the cystic fibrosis-related diabetes? The Delta 508 mutation, which I'm sure you've all heard about. So this is the main factor. This is the highest risk factor, and 80% contributes to the development of CFRD. Female sex. Women develop CFRD more commonly than in men. Presence of liver disease, and of course use of steroids. So why do we worry about cystic? I will just call it CFRD just for the sake of time, because I'm sure you all know what it is. So why do we need to worry about it, and what's the kind of the bad effect of the CFRD on the lungs and on the CF itself? So there are quite a lot of data that they impact on CFRD on survival and nutrition. So data from Cystic Fibrosis Registry showed that there is a six-fold greater mortality in individuals who have diabetes compared to the ones who don't. Reduced survival more significant in women, and it's over 16 years compared to women who do not have CFRD. There is a steady reduction in mortality in the last 15 years, and it's likely due to early recognition, more intensification of therapy. So again, the data, it goes back to the 80s when we did not have all the tools that we currently have. So if we probably look from now on, and the stats would be totally different. But again, we are collecting the data, but they're not there yet. Decline in weight and body mass index seen in the actually 4 year prior to diagnosis of cystic fibrosis-related diabetes, and it could be at the level of some development of glucose intolerance, and there are some small studies, which I'm not going to go over all the details, but they're kind of debatable. But there are some small studies that even if we treat very early on glucose intolerance state, we may prevent some decline in the lung function. But overweight and obesity actually reported more frequently in cystic fibrosis-related diabetes than without diabetes. And I know we're usually unrestricting the calories, and most of the patients need not to restrict calories or carbohydrates and have nutritional supplements. But since we're better in the diagnosis of cystic fibrosis, I see quite a few patients who were diagnosed in their 50s. So they may have regular type 2 diabetes, and they presented with just frequent sinus infections that were previously attributed to another condition, but then get tested and actually in the age get diagnosed with cystic fibrosis. So those patients may have kind of a combination of cystic fibrosis-related diabetes plus just a regular garden-variety type 2 diabetes. What is the effect of CFRD on lung function and infections? FEV1, that forced expiratory volume that you are all familiar with in diabetes, is lower usually than compared with the same age and the same duration of CF. There's also lower forced vital capacity in the patients. There's higher rate of decline in FEV1 and FVC, already starting with prediabetes, and lower at the baseline in individuals who develop diabetes 4 to 6 years later from the baseline measurement of those parameters. So you can see on the graph that there is at all the time point there is a lower FEV1 comparing to the individuals who do not have diabetes. So what is the effect on the lungs? Their higher blood sugars had been associated with structural damage of the lung tissue, and it had been detected by CT scan. So there had been shown that there's higher frequency of bronchiectasis, damage of the lung parenchyma, reduced defense against the infections. There is the term airway surface liquid, ASL, that covers the airways and sort of protects the epithelium from the entrance of the infection. It's normal when the blood sugars are in the airways, the blood sugars are usually fairly low. So that kind of coverage, that protective layer of the airways function normally in the low glucose levels. But when the glucose is increased, it actually promotes the damage of this layer and pathogen growth. So you can see that on this graph that the Pseudomonas had been growing way more in the airways on patients who diagnosed with CFRD, even with before the preclinical stage of the Pseudomonas infection, comparing to the ones who did not have diabetes. And I'm so sorry, I don't know why this whole thing moved.
Sorry, can I ask a quick question?
Mm-hmm. Yeah.
So basolateral glucose, that's the glucose in the airway surface.
Correct. Mm-hmm.
So what was the blood glucose for these two bars?
So the blood glucose were not provided in this paper. They measured specifically the glucose in the airways. Yeah, so that's a great question. So I didn't see the correlation of that with the actual blood glucose. But I'll show you the data later when the glucose in the airways started increasing after what glucose levels in the different studies.
Another question.
Yeah.
Does this apply to people who had lung transplants?
No, that was before the lung transplant. Does that apply to the lung transplant individuals? So this particular study was done in non-transplant. I don't think it was done in transplant. I haven't seen the data. Oh gosh, I don't know why. I'm so sorry. Well, I think I know because when I changed the size of the slides, I think that's how everything moved. Yeah, I don't know if you want me to change it back and see how that works. Is it okay? Can you see it? Yeah, that's what happened. Everything moved. Okay, so what is the effect on the insulin deficiency and insulin resistance? So is it just the blood sugar, or is that the insulin levels and resistance to the insulin play the role as well? So that's what the question, that was the little discussion here. So there's a reduction in inspiratory muscle and diaphragm strength in the insulin deficiency. So insulin is anabolic hormone, right? So it promotes the growth. It also prevents the breakdown of the protein. So if there is not enough, or if there's an insulin deficiency, there is a protein breakdown for the muscle to get the energy, right? Because the muscles get the energy from when glucose enters the muscle cells, right? So if there's not enough insulin, or if there's an insulin resistance, muscles not able to utilize that glucose for an energy, let's say for exercise and even for breathing. Therefore, muscles breaking down protein and fat around the muscle to be able to provide that substrate for the energy. So that's the effect of the insulin deficiency. in cystic fibrosis without diabetes, there is normally, day to day, there is increase in protein production and protein breakdown in NCF individuals just because of the breathing requires more of their energy. More of the use of the muscles, and therefore there's usually net protein balance. So there's increased production, increased utilization, so it's all kind of balanced. But when there is increase in post-meal levels, there are usually decrease in protein breakdown. So when we eat, insulin produced from the pancreas, that allows that sugar go into the cells and suppresses the higher level of the insulin, suppresses the breakdown of protein. So it sort of saves the protein for the times when we're not eating. That's the physiology, right? So that's kind of normal. In cystic fibrosis-related diabetes, there is a lower production of the insulin, plus there's an insulin resistance, which can be from use of steroids, from any infection or inflammation will increase the tissue's insulin resistance. Therefore, there's a negative protein balance or more of the catabolic state. There is, with the improved nutritional status and with the reversal of the protein catabolism, there is a stabilization of the pulmonary function. So that's kind of the hypothesis or the idea that giving the insulin early restores the muscle function and improves the lung function with that. Again, I'm so sorry. I think because I changed the size, everything moved. So what about diabetes complications? We used to say that diabetes complications are not as common in cystic fibrosis compared to type 1 or type 2 diabetes. But because now we have improved technology, we have improved treatments, individuals with CF or CF-related diabetes living healthier and longer lives. So we are seeing more and more complications. So we are seeing more both micro and macrovascular complications. So what are the microvascular? Microvascular are the complications that are affecting small vessels. Those small vessels are in kidneys, eyes, and supplying the nerves. So those are three main microvascular complications that we usually worry about in diabetes. So about the eyes, the data variable, but the retinopathy, the eye effect on the diabetes, we do see in 5 to 27% of the individuals with CFRI, and it develops anywhere from 3 to 23 years after the diagnosis. The kidneys, what's the kidney effect of the blood glucose, we see about 15 years approximately on an average after the diagnosis. And gastropathy or gastroparesis, there are multiple other reasons for gastroparesis and cystic fibrosis, but diabetes is also contributing to that. We call it autonomic dysfunction, meaning dysfunction of the internal organs. So that happens 51%, and there are no studies looking at specifically prevalence of diabetes gastroparesis because I think it's just impossible to rule out diabetes versus other things with the CF that can cause diabetes. For the macrovascular disease, for the heart, high blood pressure and high cholesterol seen more and more frequently. I could not find any specific numbers or percentage, but overall, there is no documented risk of macrovascular, of heart disease, specifically related to CFRD as of now. How do we diagnose it and how do we screen for it? So screening test, the standard and approved one is a 75-gram 2-hour oral glucose tolerance test over the age of 10 years old, and it should be done annually. So those are the guidelines for Cystic Fibrosis Society. I put on the table here what are the categories for percentage for the fasting glucose, for normal glucose tolerance test, for fasting glucose 126. So realize this is the data that I found, which was in the cystic fibrosis literature, but for diabetes literature, it's actually a difference because fasting glucose between 100 and 125 is considered pre-diabetes. So this is kind of the old data, but this is what in CF guidelines. That's why I put that in the table. But again, normal considered under 100 or pretty much 99. 100 to 125 is the pre-diabetes, and over to 126 is diabetes. But this is what it is here. For 2 hours, normal blood glucose after this glucose drink is under 140. For impaired glucose tolerance, again, listed as blood sugar less than 126 is fasting, and 2 hours between 140 and 199. For impaired plasma glucose, 99 to 125, so this is a pre-diabetes category. And definition for CFRD, fasting plasma glucose less than 126 or more than 126, but 2-hour post-meal would be over 199. So it's very common that fasting glucose would be normal in cystic fibrosis, but actually postprandial blood sugar spike. There's another category which there's still debates how much we need to worry about this category, and that's called indeterminate glycemia. So this would be with blood sugar of less than 126 for fasting. 1 hour, if we measure it, would be over 200, but it comes down quickly, and by 2 hours, the glucose is already normal. So do we need to worry about this category? We do get a lot of calls about this. Do we consider this as diabetes, or how do we deal with this finding? So indeterminate glycemia, or an INDET, associated with the higher chance of developing cystic fibrosis-related diabetes. And it's actually been shown that already at that level, it's associated with worsening of the lung function. So how do we monitor the treatment, or can we use any other tests for the diagnosis and treatment monitoring? What about hemoglobin A1C? So we use it in all other forms of diabetes, and we consider that as a ADA approved, even as a screening test. But unfortunately, this test is not accurate in cystic fibrosis. It's very underestimated glycemic control. So the levels are usually low. Some levels could be as low as in the low 5s, but blood sugars could be really high during the day. So it is not reflective of the glucose control. Now, if the hemoglobin A1C is over 6.5, which is the definition for any other diabetes, then obviously it's diabetes, but probably the actual level is even higher. So because of that, because it's not reliable, it's not recommended for screening. If it's positive, again, it's positive. If it's negative, it cannot rule out normal A1C, cannot rule out CFRD. So how can we use other tools that we have now? So we have this amazing tool, which is the continuous glucose monitoring device. It's a very cool device or tool that we use now, and use it really, really widely, and I'll show you different ones. But so this is kind of the cross section or the cut of the sensor. So the sensor is like a hair thin platinum. I think it's about 11 or 13 millimeters in different companies and different devices. So this is a cross-section of that. So it's not as big. It's just magnified on the picture. So what does it do? It's estimate the glucose in the interstitial fluid, not in the blood. So what's happening is that so blood glucose with the gradient, interstitial fluid has low glucose. Blood glucose by the gradient diffuses into the interstitial fluid. The signal from the interstitial fluid, and specifically glucose, gets into the membrane of the sensor. So the sensor has many different layers. So it has a protective layer that allows only glucose to enter. So it blocks for Oh, thank you. Oh, that's really helpful. Thank you. So it allows only glucose to enter the enzyme layer. So there is an enzyme layer underneath. It's a glucose oxidase. So what it does, it oxidates glucose to N2O2 into the proton. This proton goes to the electrode that's inside that sensor. So that electrode creates a signal. So this is if you see that little picture, so this is how the little sensor looks like. So this proton signal goes to that little white device that's attached to it that's called transmitter. And that transmitter converts that sort of electrical stimuli or this proton into the actual blood glucose value. So unfortunately, it doesn't give us right this minute what's happening in the blood, right? Because there's some delays. So there's a delay for the glucose to go from the blood into interstitial fluid. There's a delay between all these processes occur, which I just described. Yes.
Do you know how much of a delay that is?
Yeah, so we usually say it's on an average about 10-15 minutes. Yeah, which is, doesn't seem to be a lot, but it depends how fast blood sugar is going up or down, right? So the blood sugar going up or down 3, 4, 5 milligram per deciliter per minute, that's 15 minutes can translate in 60, 70 points, right? Yeah, so it depends what's the rate of change. So what are devices that we currently have available in our practice to be used? So I put this picture here. So when I started my endocrine practice, so this is what we had. This was quite a bulky device. It was made by Medtronic. It was the first device that came out in 1999. And it was super exciting because we didn't have anything else. It was kind of fun to work with because so we got only 3 days of data from this device. It was only for office use. It was not for patients to see the real-time data. So all the data were stored in this little box, and it wasn't that little. It was fairly bulky. It did require patients' input blood sugars to at least 2 to 3 times per day. And you should have wearing it constantly for 3 days, so you can't take it out even for the shower. So you have to go with it anywhere you go, or you can swim for those 3 days that we put on this device. So I had the whole box of the shower bag. So you put a little shower bag around your neck and device inside, and it's kind of tapes that water kind of goes around it and doesn't get into the bag. So it was fun to use, but still at that time that was amazing. Now we have way smaller devices. So this is a new Medtronic pump with a continuous glucose monitoring device, and you can see a little tracing of the blood sugar reflected in the actual device itself. This is the Guardian sensor that's with this device and a little transmitter. So this is the Dexcom. So we had very rarely patients using G4. That's a little older version. G5 still quite a bit. So we do have now 2 new versions of Dexcom. It's G5 and G6. G5 is covered by Medicare, but not G6. And G6 is used for all the commercial insurances. So receiver is not required. The data goes straight to the iPhone. It's Bluetooth enabled. It can go to any of the phones, plus it can go to the iWatch or actually any of the smart devices. Yes, it can go to the cheap but smart watches. It can go even to Fitbit. It can go to any of the smart devices. There's limitations of the functionality, what you can do with those watches and smart devices on your wrist, but you can see the data. You can have your followers, so you can have your family follow you, what the blood sugars are. It does have, yeah, it's pretty cool. I follow some of the patients on my phone. So the family can turn on or off the alarms. I have 5 patients who I follow, so I turn all the alarms off. Otherwise, I would be constantly up. But it's a really cool tool and it's fairly accurate. So the G5 is approved for 7 days, and G6 is approved for 10 days. G5, I think I have G6 picture too. So G5 requires 2 calibrations per day, and this is the G6. So G6 does not need to be calibrated. It's factory calibrated, and it's a 10-day wear. And up to 5 people can follow you. So MARD it stands for mean absolute relative difference. So this is the measure that we all use for all meters, all sensors to see how accurate they are. Okay. So what it reflects is the difference between the blood sugar measured by the sensor from blood sugar measured by reference device. Now, in the studies, the reference device used the lab glucose analyzer, which is way accurate than the meters. When we use just the meters that you use or the patients use in the real world, unfortunately, even sensors become less accurate because, as you see for studies, the MARD for G6 was 9%. FDA approved accuracy for the meters is MARD of 20%. So when you calibrate the device with something that's already not accurate, obviously the sensor is not measuring that accurately either. But if you do the super accurate calibration, ideally, that would be the MARD. The actual MARD is better than the meter.
Excuse me, what do you mean by 10-day wear?
10-day wear, that you put it in your arm. So this little thing stays on the arm or body or abdomen or wherever you put it. And it stays for 10 days. So for 10 days, it measures blood sugars or interstitial fluid sugar every 5 minutes. So if you want, you get as many as 288 readings per day. So you wear it for 10 days, you swim with it, you sleep with it, you take a shower, you do whatever you want with it. Ideally not putting the hot jet from jacuzzi. One of my patients tried it, it's not working. But she decided to test, it didn't work. But so as long as you don't do it, it stays in the body for 10 days. And then you just take it out and put the new one in. So this is the inserter. So it already comes with preloaded. Basically what you do is super simple. That little orange key is a stop key. So you twist it to unlock it. You put the device next to the body. I should have brought some, I didn't realize. And then you push this orange button. The sensor goes in and you just pull it out and that stays and you connect to this little transmitter. So that's what it is. Stays on the body for 10 days.
You have to change the sensor every 10 days?
Correct. Mm-hmm.
Okay.
Yeah, so you pull the old one out, throw it away, and put the new one in.
As in you do it yourself?
Oh, yeah, for sure. It takes literally 5 minutes. Yes.
Is the loader spring action or do you have to, how does it load?
It's spring-loaded. Yeah.
You don't really have to.
Oh, sorry about that.
Skin it, shoots it in. You don't have to stab yourself.
Yeah, no, you don't have to set. So, good question, actually. So, this G5 is not spring-loaded. So, G5 does have this, which patients sometimes call harpoon. So, it's a kind of the arm, and you do have to push this sensor in. It's not the most pleasant. It's not the worst thing in the world. I did it on myself many times just to try it. But yes, it is a lot of the times requires some courage to just actually push it. But this one, the new one, is spring-loaded. So you just push the button, it goes in.
How far does it go in?
I think it's either 11 or 13 millimeters.
Doesn't sound so bad.
No, it's not bad. It's very, very small. So you remove the needle guide. So it's only that thin catheter just stays inside the skin. You don't feel it at all. So I love myself to wear devices just for fun. I don't have diabetes, but it's so fun to watch what your blood sugars are changing every 5 minutes. So you don't feel it. You even forget about it, which you shouldn't forget about it. You should be looking at it, but you really just don't even remember that it's on your body. Yes. Supposedly with the new devices, the lag time a little less, but I think it's variable. It's very dependent on where on the body the sensor is, and I think it depends on individual tissues because in some patients it's amazingly accurate. And it's sensor to sensor dependent. Some sensors would be just amazingly accurate. And even for myself, sometimes I would check and it would be, so because I always check just to make sure to see if it's how accurate that is. And I would check and it's like within 1 or 2 points difference. So it's amazingly accurate. But again, realize my blood sugars are not spiking and don't go up and down that much. So if it's flat, it's just completely flat and normal.
Is that the same as whatever lag might be when you check with an actual meter, or is there?
No, because actual meter you do the blood. So the question was if there is a lag time with the meter. No, because the meter you check actual blood glucose. So with the sensor you check interstitial fluid glucose.
Oh.
Yeah. So the delay is between what you see on the meter and what's showing on the sensor. Yeah, so as an example, what is most delayed that I see is coming out of low. So if you are low and the sensor is showing 50 or 60, you already corrected, you feel fine, but the device does lag for about at least 10 minutes. So it still keep beeping on you that you're low. So I think that's the worst thing because then you feel like, oh my gosh, I'm still low. I feel okay, I corrected it, but it shows me low, so I have to eat more. So, and then you overcorrect. So we always try to tell patients, just if you feel fine, just check to be sure, but most likely it's just the delay. And then, but if, that's what people say, like empty refrigerator syndrome, right? If it's beeps on you, you feel nervous that you're going low and you just keep eating and eating, and then it shoots all the way up. Right. So there is another sensor. It's a Freestyle Libre, and you probably had seen it. It's been on the TV advertised all the time. So now we have a 14-day use available. It is factory calibrated, so you don't have to calibrate it. There is a little reader, and you can also scan it with your phone. It's a touch screen, so there's a little thing that you wear, circle that you wear on the skin, and that's changed every 14 days. And when you want to know your blood sugar, you scan and you see what the number is. So this current version is not does not have alarm and alerts like Dexcom. So Dexcom will alert you if you go low or high. It will wake you up at night if you're high or low. It depends on what parameters you set up. But Libre does not. So it's only when you are scanning and when you're looking at the numbers. It is not shared with family members or friends or spouses. So it's just what you can see either on the phone or on your screen of the reader. You can scan as many times a day as you want. I think one of my patients, he scans on an average of 104 times a day. But I usually tell patients if you wear it, just scan at least 8 to 10 times a day. Otherwise, there's no point of wearing it, right? Because you can do your 2 to 3 finger sticks per day. So it captures and stores the readings even if you do not scan. This little circle has the memory of 8 hours. So if you don't scan for 10 hours, then you lose that 2-hour data. So if you at least scan every 8 hours, when you download it, you see the 24 hours continuous data every 5 minutes. So there is another sensor that we have. It's a Guardian Connect. It was approved in March of 2018. It does require 2 calibrations per day. It's a 7-day wear. It's by Medtronic. It has an app on the phone that's called Sugar IQ. It does kind of analyze your data, and it gives you some patterns, and it gives you some analysis. For the last 3 days, you were high after your meals. You might want to consider changing your carb ratio or something like that. So it is compatible with iPhones, Android phones. It says so in the development, it's already out. And it's smart about 9 to 10%. It's rarely being used just because you still have to calibrate it, and the Guardian sensor is a little bit more kind of needy, I would say. It's how you wake up a little more. It kind of asks for more things. Even if you calibrate it in 2 hours, it may ask you to enter the blood sugar, or it may ask you to do another calibration. So sensor is very FDA safe, so it requires multiple things to make sure it stays safe in the safe zone in terms of the accuracy. So it hasn't been used that much. Now, this is a newer kind of sensor on the market. It's an implantable sensor. It's an Eversense. It was approved last year, right at the time of the American Diabetes Association, in June 2018. It does require 2 calibrations per day. There is that tiny little thing that you can see. It's implanted in the arm, right underneath the skin, and it's worn for 90 days. You do have a little transmitter. It's a completely different technology, so it's not glucose oxidase, it's not the enzyme technology, it's the light technology, right? So when you put this little sensor with the light, it's activate the sensor, and again, it gets the reading back. So you can always, this sensor, this transmitter, you can always peel off. Let's say if you do want to take a jacuzzi with a hot jet and you don't want to, to damage the transmitter, you just pull it off and then you put it back on with a tape. And you don't have to wait for any warm-up period of the sensor, or you don't have to do any new stuff with it. It works right away. So again, it stays for 3 months. It is convenient for some patients. I would say we just started using this maybe about several months ago. You have to be certified to place the sensor because it's a little minor procedure. You do a little skin cut about 0.5 centimeter. Usually doesn't leave the scar, but some patients who are prone to any of the scar or keloid scar formation may have a little scar tissue. So I think it's convenient for someone who does sports, for someone who likes to hike and travel, because the Dexcom may take quite a bit of space. You saw this, the inserter in your bag. This one needs just that little transmitter and the tiniest charger for this transmitter. So MARD is 8.5%, so it's a little bit more accurate than other sensors. Now, in Europe, it's approved for 180 days, for 6 months. Our FDA so far is approved it only for 90 days, so the studies are ongoing to prove how accurate and safe it is for the 180 days. But some patients really like it, yeah.
Has it been used in transplantation?
Not yet. I have not seen it's been used in transplantation. Oh, has this device been used in transplant patients? No, not yet. Yeah. So how do we use this technology in cystic fibrosis, and what's the data? So what we know that a CGM detects earlier abnormalities in the glucose than we can see on A1C or other tests that we use, or even glucose tolerance test. So the CGM was validated in 102 children and adolescents in the study and showed that it was reliable and reproducible tools, and the data from the sensor correlate with meter data. 1/3 of individuals who actually had a normal glucose tolerance test found to have spikes with over 200 blood sugars on the CGM. And you can see how are the blood sugars on continuous glucose monitoring device. So this is just a period of 1 day, but you can see that there could be at least 1 or more spikes during the day with those high blood sugars that we don't see. Because if we measure glucose here or here, we would never know that this spike existed. So what are the reports of the use that in CFRD, and can we detect earlier diagnosis of diabetes and use it? So CGM in cystic fibrosis patients, can it predict the pulmonary exacerbation? So there was a small study looking at using the Dexcom, comparing with the just blood sugar meters. And it had been shown that, I think I made them too small, but, and I think again, it's the print that I changed. The Dexcom unmasked for 3 months use had the patients who had pulmonary exacerbations had higher blood sugars at all time points comparing to the ones who did not have exacerbations within 3 months. So it's kind of predicted that something is going to happen. And I usually tell patients that if blood sugars are high for unclear reason just by itself, there's something is coming most likely. And that's what usually the case. In a few days, something will show up, some kind of viral infection, so the higher blood sugars would be like a prodrome or like your compass to see where I'm going. That's very common. So SAG stands for sensor augmented glucose insulin pump that was used in patients with cystic fibrosis related diabetes who had delta 508 mutation with a very poor control. And you can see how nicely the lines with the use of the pump and sensors together for the glucose control. This was just a case report. So what are the benefits of tight control in general and in CFRD? So in general, we know from the data of type 1 diabetes, the study DCCT is Diabetes Control and Complication Trial that started in 1983 and was the patients were followed for 6.5 years in type 1 diabetes. So it shows that the tight control reduced all the microvascular complications significantly. Retinopathy by 65%, nephropathy by 54%, neuropathy by 60%. Risk of cardiovascular disease also had been reduced markedly with the use of the tight control or kind of intense therapy. And non-fatal myocardial infarction, stroke, and death from any cardiovascular disease was reduced by more than a half. So the data, the cohort from that study from 1983 is still being followed. And interestingly, that patients now, so they were on intense control arm was for 6.5 years, and the control, just a regular control arm. So they were followed as an interventional study for 6.5 years. Then for after that, patients were just asked to participate in the observational phase of the trial, but they did not go to the doctors that frequently, just the usual standard care, and they did not require, so many finger sticks and so on. So we still have data still coming of this trial. So now it's over 30 years after the completion of this intense group. And interestingly, that the group that was initially assigned to intense therapy still has way fewer complications than patients who were assigned to just conventional care. So it's considered like a legacy effect, or even over the years, it still persists. So whether we have the same in CFRD, we don't know because there is no data. So what do we know about the effect of control in cystic fibrosis related diabetes? Again, as I mentioned previously, we do know that pulmonary function begins to decline several years, could be 4 to 6 years before the onset of CFRD, already in the pre-diabetes period. Rate of decline directly related to the severity of the insulin deficiency for the reasons that we've talked about. Insulin insufficiency compromises nutritional status by, again, causing this catabolic state for the body. There was a study published in Diabetes Care in 2009 for CFRD therapy study group, and it was a multi-center randomized placebo-controlled trial. It showed that insulin therapy can reverse chronic weight loss in adults with cystic fibrosis-related diabetes who were fasting glucose or negative. So patients with CFRD, some studies divide by FH positive or FH negative, meaning fasting glucose, fasting hyperglycemia, or fasting normal hyperglycemia plus or minus, right? So even in the patients who wake up with normal blood sugars but have higher blood sugars during the day, early insulin therapy reverse some of the nutritional deficiencies. So what are the other metabolic effects of the blood glucose? And somebody asked about what is the blood sugar level actually in the blood that already causes the higher level of the glucose in the airway and kind of damages this protective layer. So it has been shown that even blood glucose after 144, over 144, already has some higher glucose concentration in the lungs and the airways, and promote the growth. Sorry, did you have a question?
I did.
Yeah.
What's the difference between like non-cystic fibrosis diabetes and CF diabetes? In other words, usually people who have diabetes can't lose weight, and then people with CF diabetes seem to lose weight. What's the difference?
Yes. Oh, excellent question. I actually had this table, but because I was told that I can only speak for 30 minutes, which I'm probably over, so I deleted this. The most common type of diabetes is type 2 diabetes, right? So the last common is type 1 diabetes. So type 2 diabetes characterized by insulin resistance and relative insulin deficiency. So there's tons of insulin produced, but this insulin is not enough to cover the degree of insulin resistance, right? So those individuals, this is type 2 diabetes. So those individuals usually the diabetes is a genetic factor, but a lot of that is environmental. So it's inactivity, or it is the food that people are eating. So that can be sometimes either reversed or at least improved with the diet and exercise. Type 1 diabetes, when there is an absence of or insulin deficiency, which is when pancreas is destroyed by immune system, by body feeling like pancreas is a foreign body and attacking the beta cells that are producing insulin, and insulin is not being produced, insulin deficiency. There is variable degree of insulin resistance. For cystic fibrosis diabetes, there is always some basal production of insulin. Not enough to sometimes to cover basal needs, and that depends on the status, on the infectious status, of the steroid status, on the transplant status, and the medication that we use for transplant. So patients with CFRD develop diabetes later in life than type 2 diabetes, but sometimes also later. Type 2 diabetes later or variable age. Type 1 diabetes, most of the patients develop it as children, although now we see more in the adults. So that insulin deficiency factor that is more in type 1 diabetes and CFRD a lot more than in type 2 diabetes. So in type 2 diabetes, there's still plenty of insulin to prevent that weight loss, to prevent this catabolic state. So therefore, patients are able to somewhat utilize this glucose, so they don't develop the ketones, they don't develop muscle and protein breakdown, because there's enough insulin to help with that. But there's not enough insulin to improve the glucose control, to get this glucose and bring it into the cells to be utilized by the tissue. So if we measure insulin levels in CFRD, there could be some 5 or less, or 10 the most. When we measure the levels in insulin levels in someone who has type 2 diabetes and insulin resistant and has not developed insulin deficiency, insulin levels could be 100, up to 500. I've seen the levels. Does it make sense? Did it answer your question? So there's no catabolic state in type 2 diabetes. So there's more of the storage of the nutrients. Comparing to the CFRD, there's more of the utilization of the nutrients and catabolism because of the one of the not enough insulin. 2 is because just in general protein and the whole body metabolism is way faster than in regular type 2 diabetes. Okay.
And just my understanding is with CFRD, if we have a blood sugar of 500, 600, we're not going to pass out. We're not going to go into a coma. But if we, type 1 diabetic would.
Correct.
Right?
Yeah.
So we have the good kind of diabetes.
True. Yes, I can't say it's a good type of diabetes, but yes, this is true because, as I just mentioned, that type 1 diabetes patients would not produce any insulin. with the CF, you're producing some insulin. So again, it's small amount as a baseline. It's not enough to cover the high blood sugars, but it's enough to prevent the ketone formation. Right. It's enough to prevent the fat breakdown to the point that and the liver to avoid that excessive ketones. Right. So that's why type 1 diabetes patients would usually develop decay within a few hours of the high blood sugar, could be 4 to 6 hours. For cystic fibrosis, usually decay never happens because that basal small level of insulin is enough to prevent that. Yeah, correct. Yeah.
We have an online question from Maggie. She said, tell Dr. Basina, this is her former patient, Maggie, now living in the UK. And I want to ask her if she has a favorite insulin pump. Is one pump better than another for CFRD use?
Hi, Maggie. So great to hear from you. Can I answer that in 10 minutes when I get to the pumps?
She said yes.
Okay, great. So I'll get to the pump. So I talked to you about CGM, so we'll get to the pump. And sorry, tell me if I'm already over time. So anyway, the hyperglycemia increases the oxidative stress, and even at the prediabetes level, it's kind of the higher the glucose levels in the airways, it's a pro-bacteria growth factor in the airways. So what about hypoglycemia? I know we usually worry about low blood sugars anywhere. It's not a pleasant feeling to have low blood sugars. If any of you had it, that's definitely not fun. So what do we know about hypoglycemia in cystic fibrosis-related diabetes, and pretty much in any diabetes, because this is our main limiting factor for tight control, right? Because we want to tight control, but it's always a risk of low blood sugar, so we're sort of trying to balance between highs and lows. So this study was done in an inpatient and looked at hypoglycemia, hyperglycemia, and glucose variability in patients with insulin-treated CFRD. And so after discharge, they did this survival analysis for 3.5 years of the follow-up. So the red line estimates hypoglycemia if it was present on admission. And the black line estimates of no hypoglycemia. So even if the initial few months, there was a maybe slightly higher rate of mortality, but overall, long term, it didn't change the risk of the mortality. So, but in the first few years, there was a higher rate of mortality for someone who had lower blood glucose. But interestingly, in this study, hyperglycemia was and glucose variability did not affect readmission and mortality, although the study initially was powered mostly for hypoglycemia, not for hyperglycemia. And it was a very small study. Yes. Oh, did you have a question? No. Okay.
I was talking to myself basically inside my head.
Okay. So now we're coming to insulin pumps. So the first insulin pump was like a little, or not a little backpack. I think it was over 20 pounds. And it was actually delivering insulin intravenously. And even at that time, it was 1963, it was such an excitement because it did work, because insulin was given straight to the vein, straight to the blood. Since that, we made a long way. So those are the other pumps that we used. So I think we still have at Stanford this Bi-Stator, which actually works it was the first sort of prototype of the closed loop pump. And a lot of the studies were done. We still have it in pediatrics stored somewhere. So then we had this pump, which was kind of a huge accomplishment too. So because of it didn't it couldn't fit the insulin inside, and it could not deliver insulin at a slow rate. So in order to use this pump, we had to dilute the insulin. So the actual insulin concentration, the usual one is U100, which is 100 units in 1 ml. For this pump, because the slow rate could not be delivered, so this pump could only use U40 insulin, so 40 units in 1 cc. So we had to dilute it. So what are the principles of the pump? So the pump delivers small amount of insulin through this little plastic catheter, usually in the subcutaneous tissue. And so it delivers basal insulin 24/7, and then you push the button when you're eating, and the pump is programmed for what is the insulin to carb ratio, what is the correction factor to bring glucose to the target where we want it to be, and what is the active of the action time of the insulin. So when you just put your current blood sugar and you input your amount of carbs, and pump does the rest of the math and delivers the insulin. So here are what our current pumps on the market. So this is the older Medtronic pump still used, the fairly small compared to the first picture I showed you. This is a tandem pump, T-Slim or X, or there are two versions that are two models that are now available in the market. And you can see Ms. Idaho is wearing one. And this is 670G or 630G Medtronic insulin pump that operates with the meter that beams into the pump and a little sensor that also shows on the pump goes into the pump. So what is, let me show you other pumps. So this is the Omnipod. So it's the only pump that does not have the tubing. So there is a pod that's on the body. The good thing about this pump is that, and the kids love it because you don't have to actually insert anything. So you just put that on your arm or body to tape it, and then you press the button on this PDM and you hear a click, the needle goes in so you never see it. So it's good for someone who doesn't like to, or has some needle phobia, does not like to take shots or actually put any of the infusion sets, even though when they're spring loaded. So what is my favorite pump? I don't have stocks in any of those companies, and realize that the technology changes pretty much every few months at this point. So we used to use a lot of the Medtronic pumps, 670G, before Tandem or T-Slim came out with a new version of their pump. Now we're kind of using a lot more of the Tandem because patients usually like the Dexcom way more than the Medtronic sensor. And it's more accurate, does not require calibration. It's less needy than Medtronic pump. If any of you, and I think I saw some of the pumps, so wearing Medtronic pump, you know that it's got the Guardian sensor, again, because of that's the first closed loop or hybrid closed loop that was approved, and I'll show you a little bit more about the closed loop. It has a lot of the protection against any of something that's going wrong. So it does beep on you a lot. It wants a lot of calibrations. It wants a lot of extra blood sugars. Dexcom doesn't do it, and that's why patients do like the Dexcom G6 with the Tandem X2 or T-Slim X2 insulin pump. So that's the most popular one now, and I'll show you what the features are of this particular pump that makes it more likable for the patients. So before we go into that specific feature, so what are the artificial pancreas and what are our future directions in technology? And that's my favorite topic. I can talk about this for a few hours if you have time. So what is the artificial pancreas? What are the components of that? So we have a sensor that gets the data and sends the sensor to the receiver. Receiver can be either the phone, the pump itself. Then receiver analyzes the data and it sends it to the pump, kind of analyzes it through the algorithm to what to do with this data, right? Do I need to decrease insulin? Do I need to increase the insulin? And then it sends the information to the insulin pump, and insulin pump delivers small amount of insulin what's needed, or suspends the pump if blood sugar is going low, right? So it's kind of interesting and complicated system at the same time, right? Because all the kind of steps need to function well in order for the whole system to work well. In addition, the infusion set where the insulin going through need to be in a good position and not in the scar tissue, and need to have a good amount of insulin. So that's why it's not easy, right? So a lot of those steps need to be functioning in order for the system to function well. So the algorithms could be different in different systems. For the most part, the algorithm uses there are two main ones that are used, and I don't have that slide, but they're either model predictive controller or proportional integral derivative. But to say it in a simple word is that it's like a chess game. So if you're playing chess and glucose is your opponent, right? So you're making one step, glucose changed the direction, you made a different step. Algorithm completely changes the direction. So instead of giving more insulin, it's suspending the insulin. So every 5 minutes, it assesses what glucose is doing and changes the direction. And direction with the sending signal to the pump how to deliver insulin. Yes.
So is this designed for when you're like sitting and resting? Because I know with exercise that also helps reduce glucose. So if you like eat a big carby thing and then you go to the gym, you might get a bunch of insulin and then you work out and then it can crash.
Right.
So do you like tell it, chill, I'm going to work out? Or?
Yes, so excellent question. And the question was, how do we use those devices? Are they useful for workout, for physical activity, or they're more dangerous for physical activity? Those devices actually are the most helpful for physical activity because let's say you're on long-acting insulin and you injected your Lantus or whatever insulin long-acting you're using, and you decided to go for a run or to go for a bike ride or hiking up the hill, right? Your Lantus is in you. You can't turn it off, right? So you have to eat in order to feed that insulin that's in the body. The pumps have only short-acting insulin, so it would be either Novolog or Humalog or any other short-acting insulin that's on the market. And if you're going hiking, you would say, I don't need this all insulin while I'm hiking. I'm going to turn down my insulin delivery by 50%. At the same time, with the smart pumps, you can set up your higher target. Let's say if the pump is adjusting with those algorithms, you can say, okay, my usual target, I want to be 100 or 120. When I'm exercising, I want to be more careful, and I want my blood sugar to be 150. So this whole algorithm resets. And it aims for the blood sugar 150 instead of your current 120 that is set up. Yeah, so it's actually the best thing to use for exercise if possible. The type 1 individuals who use those devices more, so there was a 16 or 17 mile marathon in New York. There were like close to 20 patients, type 1 individuals participated. So Medtronic, to test their system, they gave them all 670G to participate in that marathon. And I think they did 16 or 17 miles. And everyone did great. They didn't go low, they didn't go high. One patient went actually into ketoacidosis, but she didn't know she was running, and the infusion set actually got turned off, dislodged, so she didn't see it. When she found it, she was already not feeling well, so she had to go to ER. But everyone else did great. So, but that can happen with anything. So we talked about those delays, and because of the lack of the time, I probably wouldn't go into details, but again, delay anywhere from 5 to 15 minutes. That the insulin delayed absorption, the insulin reaching the liver to prevent the liver making extra glucose, plus the sensor, so all that creates that 10-15 minutes delay. So this is in real time. This is actually the picture that I snipped from one of my patients who he's using a lot of insulin, as you can see. He doesn't have CF, but he is eating quite a bit. If you can see all those orange little boxes, that's when he eats. So he's a snacker. He does like carbs. So as you can see, he does eat quite a bit of frequently during the day. With snacks, and you can see those pink or light purple little bars. This is how the pump handle is. So that's the closed loop. So when his blood sugars go up, you can see that pump produces more insulin. When blood sugar goes down, the pump suspends, so he's not going to go low. So the pump is working hard in the background. So as you can see, this was comparison to what he was before the pump. So the orange or peach color represent to what his blood sugar control was on a sensor before using this closed loop system. And you can see how everything is way down when he's using the closed loop. So you can see the green bar represents what is the percentage of time over 24 hours or average for 2 weeks. That he spends in target range. In target range, we use 70 to 180 of when he's doing it by himself comparing to what pump is using. So you can see that the bar almost doubled in the height. So there are studies doing the bihormonal pancreas. I showed you the kind of the older version of it. So this is how we did the study here at Stanford with this bihormonal pancreas. So it delivers both glucagon and the insulin. So it's now the new pump device. It's called iLet. It's not a small device, but it's way smaller than what patients had. But this is what one of the patients actually when we did it here. So there were 2 tandem pumps. One has glucagon, one has insulin. They were the iPhone and the Dexcom were kind of glued together, and the information was going through that algorithm and sending to one of the pumps to deliver either a small amount of insulin or a small amount of glucagon. To keep the blood sugar controlled. So again, we are going to start a new study, I think November or December at Stanford for the way better looking device for bihormonal. Yes.
Is glucagon production also impaired in cystic fibrosis?
So it's a great question. Is glucagon also impaired in cystic fibrosis? It's slightly impaired in terms of the quantity, but it's more of the how it's released and is impaired. So alpha cells are in the pancreas releasing the glucagon when blood sugar go low and when insulin level goes down. Right. So if there's an insulin deficiency, when there's plenty of insulin, let's say postprandial, insulin level goes up and it suppresses the glucagon through the crosstalk between alpha and beta cells in the pancreas. So when there's not enough insulin, glucagon is not getting enough suppression. So there's overall little small amount of insulin, glucagon, but it's constantly being produced. So it's not suppressed as it's supposed to be normally suppressing. So because it's not suppressed, glucagon, what it does, it goes to the liver and it tells liver to make extra glucose. So liver constantly working on producing the extra glucose. So because of that overall baseline higher levels of glucagon. Does it make sense? So because of that, there is a less of the storage of this glycogen or glucose when it's supposed to be used for the starvation periods, right? So it's actually being produced and made when it's not supposed to, right? So I don't know if it's answered your question, but yes, there's some small deficiency, but overall it's just the pulsatility and production is very different. Yes.
I'm a little confused, just to clarify. So is the closed loop system already available, or is it not on the market?
So this particular one, so is the closed loop available or not yet on the market? So this particular, the bihormonal one is not on the market yet. Yes, before that, yes. So the 670G, which is the Medtronic hybrid called hybrid closed loop, and the Tandem T-Slim X2, yes, those two are available. So Medtronic is able to adjust for highs and lows again, you still have to, it's a hybrid. So you still have to enter your carbs and you still have to give yourself bolus before the meals. It's not fast enough to react for the meals. We're actually saying the better results we see if those boluses for meals delivered at least 15 minutes before you eat. Tandem has the feature of basal IQ, which means that it suspends for the lows, but it does not react for the highs yet. The new algorithm for the Tandem is supposed to come out at the end of August or September, when it also will be adjusting for highs. So that's why I said, Maggie, now that I think at this time that we are on now, I think T-Slim Tandem is the most usable pump. I'm not sure it's available in the UK. I think it's only Medtronic is available in the UK. But that's the more user-friendly pump, I would say. Medtronic does work, but it's very needy. One of my patients called it as it's your, like, it does work well, but it's your kind of needy and annoying girlfriend who constantly wants something from you. But it does work. I can't. So what are the tools that we have available? So we have available those in-pen or smart pens. I think this is a great tool. So one, it can deliver the insulin with half units, and sometimes individuals could be very sensitive, and half a unit could be a big difference, right? So it delivers in half units. It's connected to your phone. So there is an app on the phone that you can see. It's right like this. So it will also show you how much active insulin you have. So it's pretty much programmed as a pump. So you put your carb amount, the Dexcom data goes into the app, and it calculates for you how much insulin you need to take for this particular meal. So you don't have to do any math. I think it's great for us as healthcare providers, because when patients come and they say, oh yeah, I did take my insulin here, and I have no idea whether that happened or not. So in this, I can, because it has a little cap that is Bluetooth enabled, and whenever you push it for taking insulin, it's obviously, if you push it outside the body, that still goes into the pump, into the app, but that we cannot help. But if you push it as it's supposed to be, then the data goes straight into the phone and it stores it. And I can see all the data. For us, it's really good to analyze that, to see how we can help with the adjustments to have it. Also, I think for you, it's so useful. Like, I'm sure all of you have this issue. I have this for sure. I would do something, and then 5 minutes later, I get distracted with 5 other things, and I'm thinking, did I really do it? Did I take my vitamin or whatever the pill is? And I look for, I remember I put it here, but I don't remember taking it in my mouth. The same thing with the insulin, right? You would think, oh, did I really take it or not? Or should I take another one? And of course, most of the time you wouldn't take another one, because that will cause worse consequences if you don't take it. But here you can see in the actual device, and you can see, did I take this insulin? So I did, or I actually didn't take it. So then you would take your insulin. So they are available commercially. You can get them through any of the pharmacy. The coverage has not been that great yet. Supposedly it should be covered by Medicare, not that much by Medi-Cal, but all the CCS and GHPP insurances have better coverage than just plain Medi-Cal, so can be covered if needed. So how do we use the CF technology and CFRD? So again, it's a lot of factors that contribute to glucose variability: the lung status, the infection status, the nutritional status, the higher amount of carbs that you should be eating with increased caloric requirements. So those are just a table for how much more of the percentage of the food that we usually recommend for cystic fibrosis, and usually your nutritionist recommend. Again, because of that higher body overall metabolism. So the pumps, again, deliver as many boluses as you need. And as I showed you in one of my patients who does eat frequent snacks, so the benefit of the pump that it's not only delivering this insulin without extra shots, but it also will calculate how much active insulin stays after the previous injection, and it would subtract it to prevent the stacking of the insulin to get to the low blood sugars. Unfortunately, only 28% of the adults. So we are recommending annual oral glucose tolerance testing for CF, but unfortunately, it's not that easy. And all you who have done it, this is a nasty drink to drink, and then ideally we should do it fasting. And to spend another 2 hours in the clinic or in the lab to do this test that does time consuming and as accurate as CGM. So, although guidelines do exist that to do annual testing, by the statistics, only 28% of the adults are actually tested on an annual basis for all glucose tolerance tests. Could we use CGM to predict it, as we previously mentioned? So we can use it. And the study that was done with simultaneous use of the CGM, comparing it to the oral glucose tolerance test, they did 75 gram 1 and 2 hours, and they did the 3-day of the monitoring of the CGM. They looked at the 5-year follow-up from baseline, looking at the BMI and FEV1. And the full data was available for 18 patients. And it was a strong correlation of the OGTT for the 1 hour in CGM comparing to the 2 hours when the blood sugar already coming down. R is the relative risk. The correlation coefficient. I think for this one, correlation coefficient with CGM with OGTT. So the closer to 1, the better is the result, right? So we're usually saying if it's over 0.5, it's already relatively good correlation. Yeah. That time, yes, sorry. Okay.
This is from Maggie. She says, I'm getting my T-Slim in August.
Oh, nice.
I have my first one you convinced me to get. I have pushed Tandem to get it here, and it finally was approved. I am super excited to get the newest pump.
Oh, wonderful. I'm so happy. I hope you get a Dexcom G6 too. That will work with it, with the newer version of that. Wonderful. That's great. Okay, so I'm going to skip that. Okay, so one more, just a slide that's the future that we're hoping for with the transplant. This is the slide for the patient who is a sick 14-year-old child who developed diabetes very early in life, who had liver disease, lung disease, and he underwent transplant. He had multiple admissions for multi-resistant infection, so he underwent transplantation for both lung, liver, and the beta cells, the islet cells of the pancreas. And you can see that his insulin requirements declined and his blood sugar stayed well. And he stimulated C-peptide after this pancreas transplant, which is C-peptide is a measure of how much insulin is produced. Stayed really nicely. The beta cells that were implanted were able to function and produce this insulin. And there is a burnout. Diabetes, CF itself is not easy. Diabetes is even more contributing to that. So it's work 24/7, and it's hard and it's exhausting. So the more we can possibly get done to make it easier for any of the patients, that's the goal. Sorry, I went way over time.
Thank you so much for your wonderful talk. We wanted to give you
that's so cute. Thank you so much.
There you go.
Thank you.
And thank you so much for your talk.
Thank you.
Thank you.